topic. It is polycystic ovarian syndrome, Sheehan syndrome, then testicular feminization syndrome, Chiari-Fromel, it is hyperprolactinemia, Chiari-Fromel, and what else? Mandip Singh came to us. Chiari-Fromel, what else? Itsenka-Cushing syndrome may be present. No, that's all, especially polycystic ovarian syndrome, because a lot of KROK devoted to this topic. It's maybe monophase temperature, it's maybe they describe your enlargement of the ovaries, it's maybe delay of menstruation, any symptoms. Так, Tchunia came to us. That's why disorders of the menstrual cycle. Guys, pay attention to classification of amenorrhea. What is the causes of amenorrhea? What does it mean, amenorrhea? And neuroendocrine syndrome. In KROK test present preclimacteric premenstrual syndrome present in KROK tests. And post-castration syndrome. It is syndrome which occur if a young woman perform operation on ovaries, castration. We remove the ovaries. Usually present the KROK test devoted to this topic. That's why repeated neuroendocrine syndrome. Then juvenile bleedings. What are the reasons of juvenile bleeding? And especially pay attention to the treatment of juvenile bleeding. Maybe question on exam. When they describe you the clinical picture of bleeding in young girl, 14 years old, and ask you what to do, and give you the options. On Monday, I hope that we will meet. Guys, I don't know exactly because it will be again meeting. That's why let's solve this now. We will meet with you at 10 o'clock on Monday, at 10 o'clock. Yes. Now, students, how many students? 10 students, 9 together with me, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9 students, yes. And now absent Kaushal, absent Milimba, and Yamin monitor. Guys, let's read the test. And you see, we don't pass this test. It is test devoted to obstetric operations. Pregnant woman, 35 weeks of pregnancy, they mean, age 25 years, was admitted to the hospital because of bloody discharges. In her medical history, there were 2 artificial abortions in a period of 28 to 32 weeks. There was noted the onset of hemorrhage, and ultrasound showed placenta presentation. The uterus in normal tonus, the fetal position is transverse. First position, it means that fetus head on the left side. Heartbeat clear, rhythmic 140. What is the further tactic of the pregnant woman care? Guys, no, usually if it is I hope you know that what does it mean, placenta presentation? No, guys, tell me please. Who know?
It's
Yes,
placenta
ma'am.
previa.
Yes, you know, when placenta cover internal walls of the uterus, yes? And usually bleeding appear without any reason. Yes, she came at the age of pregnancy, 35 weeks, yes. No, they told you that in a period, 28, maybe he was at home. Usually I want to say that a woman with placenta presentation or pregnancy need to be in the hospital. From the moment when we set the diagnosis to the moment of labor. Так, Milimba came to us, yes. Так, guys, I need to make screen 1 minute, please. Так, screen. Uterus in normotonus. Usually, if it is placenta previa, there is no hypertonus of the utero as we have in placenta abrupta. Yes, and they suggested you the options to perform delivery by means of cesarean, to perform hemotransfusion and prolong pregnancy, to introduce the drugs, increase blood coagulation. It is forbidden because we can cause other aggravations of the condition and development of thromb in the vessels, yes, thromboembolia. Simulate the delivery by intravenous introduction of oxytocin. If it is placenta previa and cover external os, only what we receive complications. Yes, to keep the intensity of hemorrhage under observation and after the bleeding is controlled to prolong the pregnancy. But what we have now, she has bloody discharges. Condition of the fetus is not suffer. Yes, according to protocols, we can prolong the pregnancy, but in her medical history, she has bleeding every time at the age of 28 to 32 weeks. That's why we have bleeding, we have placenta previa, and if you read about the placenta previa, usually you need to choose for cesarean section. Keyword bleeding, placenta previa. The next, guys, condition of parturient woman has been good for 2 hours after live birth. Uterus is thick, globe-shaped. Its bottom is at the level of umbilicus, bleeding absent. The clamp put on the umbilical cord remains at the same level, and when the woman takes a deep breath or she is being pressed over the symphysis with the verge of a hand, the umbilical cord draws into vagina. What does it mean, guys? This condition, who know?
It means placenta is not detached here.
Who answer me?
Dunya.
Hunya, thank you. I pointed you that you are active today. Yes, it means you are quite right. The placenta is not separated. Yes, that bloody discharges from the sexual tract are absent. What is the doctor's further tactic? And what is the, of course, right answer to do manual removal of afterbirth. Afterbirth, it is placenta together with membranes. But pay attention to the time, guys. 2 hours doctor wait, and it is mistake of the doctor because according to new protocols we can wait 30 minutes, and if there is no signs of placenta separation, we perform manual removal of the placenta. Other methods which are here we are not use. Then next, and then next. Так, examination of just bone placenta reveals defect 2 to 3 centimeters. Hemorrhage absent. What management is the most reasonable? Guys, of course, even if there is no, in order to confuse you, they write hemorrhage is absent. In any case, if the doctor see defect of placenta, she need to perform manual revision of the uterine cavity. Yes, we need to remove this lobe of placenta. It is defect of placenta. Usually it is the defect of the lobe of placenta. One lobe of placenta stay in the uterus. Yes, if we stay in the uterus, this lobe, maybe later bleeding or maybe septic condition, inflammation due to this placental tissues which we stay in the uterus. That's why manual no here manual revision of the uterine cavity. Yes, it is right. Uterotonics cannot give us anything. Message also we cannot separate this lobe of placenta. Supervision gives us only complications, we lost the time. And instrumental uterine cavity revision we do if after labor past 2 hours and more, when the cervix contracted. In this case, we do this, but usually just after labor, we perform manual revision of the uterus. Number 4. Pregnant woman in her 8th week was admitted to the hospital for artificial abortion. In course of operation during dilation of the cervical canal, cervical canal of the uterus by means of Gegard dilator number 8, the doctor suspected uterine perforation. What is the immediate tactic for confirmation of this diagnosis? Guys, I don't ask you, we discussed this KROK test many times. It is uterine probing, yes, and it is very popular in KROK. Uterine probing. The next, 30 years old primigravida, first labor, or woman has got intensive labor pain every 1-2 minutes that last 50 seconds. The disengagement has started. The perineum with the height of 4 centimeters has grown pale. What actions are necessary in this situation? Guys, right answer, episiotomy. Who can explain me why we need to do here episiotomy? Right?
Perineum height is 4 centimeters, so it's very high perineum and
Oh,
it has
thank you,
grown.
my dear. I see you listen me, Thunya, very attentively. I want to ask you what marks you have in gynecology and obstetrics on the 4th and 5th course, Thunya.
Satisfactory.
You don't know?
It's
3?
satisfactory marks 3. Yes.
3? My marks higher, I want to say, because you every time ready to answer, and I see you listen for me. Thank you,
Thank you.
Thunya. Так, number, guys, but you need to know that mark, it is we summarize the marks from the 4th, 5th course and 6th course. You know about it, rating, we name this, yes? We summarize it, and it is the 3 marks usually. And no, maybe become more higher. And guys, if you pass KROK, very good, and you have a high percent of right answers, you can usually state commission change your mark, yes, for more high mark. Then number 6 test. 30 years old woman is in her second labor that has been lasting for 14 hours. Fetal heartbeat are muffled, arrhythmic, 100 in a minute. Vaginal examination results. Cervical dilation complete. Fetal heart closed, close to the exit of the small pelvis, no, closely to the exit of the small pelvis. Sagittal suture has the direct diameter. Small crown is closely to the pubic. What is the further tactic of labor management? Guys, what we have here, what condition we have in this test? No. More.
Inertia.
No, guys, it's not inertia. What we have here? Fetal heartbeat are muffled, arrhythmic, and 100. It is especially if it is muffled, arrhythmic, and decrease. Yes, usually a normal heartbeat 120 to 160. Yes, it is fetal distress. You see, according to the test, sagittal suture in the direct diameter. Direct, it is anterior posterior size of the pelvic outlet. Yes, it means that where fetus head on the pelvic floor. Yes, and how we can help. If we wait, fetus can die because condition is very severe. It is severe distress. I told you every time, guys, acceleration, it is compensation of the fetus answer with compensation. Increase heart rate in order to increase the level of oxygen. If the fetus lose opportunity to compensate this decrease of oxygen and blood flow, we receive what? Bradycardia, deceleration of the fetal heartbeat. It is very severe, and doctor in this case cannot wait. He need to finish labor, yes, and according to this, that sagittal suture and the direct diameter, we use obstetric, we need to use obstetric forceps. Labor stimulation by means of oxytocin take a time. That's why fetus can die. Caesarea section impossible because the fetus head on the pelvic floor inside the pelvic cavity. Craniodermal forceps we don't use now, and cavity forceps. I told you here, confused me test. Here they need to write use of typical forceps, use of outlet forceps, but present you see cavity forceps. Yes, cavity forceps we use if the fetus head don't reach the pelvic floor. They can tell you in KROK test that fetus head, for example, in the narrow part of the small pelvis, yes, or in the wide part of the small pelvis. In this case, cavity forceps. Now here, use of
Teacher,
obstetric, yes,
is open forceps the same thing as use of obstetrics forceps?
apply no forceps, use of obstetric forceps, it's the same. Yes,
Because some
but
questions they say open forceps. So
no, in KROK open forceps at all, to my mind, it is wrong, maybe wrong word. Obstetric forceps and cavity forceps. These forceps, when you see that fetus head is on the pelvic floor, usually they tell you that sagittal suture in the direct diameter or anterior posterior diameter, small crown on the pelvic floor, it means the sagittal suture in the direct diameter. Yes, they can give you use of low forceps, use of typical forceps. It is the same as outlet forceps, which we have here. Use of atypical forceps or high forceps, it is cavity forceps, guys, and maybe a different name, but pelvic fetus head on the pelvic floor, it is outlet forceps, the same as, no, remember this only, low forceps and typical forceps. And if the fetus head in the cavity of the pelvis, wide or narrow part of the pelvis, it is atypical forceps or high forceps or cavity forceps. Apply open forceps. No, open forceps, I don't know at all. What does they mean? Так. After delivery and revision of placenta, there was found the defect of placental lobe. General condition of the woman normal, uterus firm, there is moderate blood discharge. Inspection of birth canal with speculas, not mirrors, wrong, shows absence of lacerations and rupture, it's wrong, and you need to be here, and ruptures. What action is necessary? Yes, no, if we have defect of the lobe of placenta, very easy. Defect of the lobe, it is a manual exploration of the uterine cavity. Manual, more better to say manual revision of the uterine cavity. Yes, other methods don't give us at all and not useful in this case. Number 8, 28-year-old parturient complains about headache, vision impairment, psychic inhibition, objectively BP 100 to 110, evident edema of the legs and anterior abdomen wall. Fetus heart is in the area, fetus head is in the area of the small pelvis. No, not right. Maybe in the small pelvis. What does it mean? Area of the small pelvis. In the small pelvis. Fetal heartbeat clear, rhythmic 190. You see here acceleration of the fetal heartbeat. Internal investigation revealed complete cervical dilation. Fetus head was in the area again of the small pelvis. What management of labor should be chosen? Forceps, you see here, operation, caesarea section, embryotomy, conservative labor management with episiotomy, stimulation of labor activity. Guys, I want to ask you, what pathology we have in this test? Так, Хуан Самимахантия. It is headache, impairment, inhibition. No, it is symptoms which prevent eclampsia. It is severe preeclampsia, yes, evident edema, BP you see 100, 110, yeah, 110. Eclampsia when we have CISOs, yes. Preeclampsia, it's maybe vision no, maybe this preeclampsia transformed to eclampsia, but here it is severe preeclampsia because it is vision impairment, psychic inhibition, headache, and edema plus high BP. Yes, diastolic pressure every time. I told you to pay attention to diastolic pressure. Yes, and what else we have here? Preeclampsia together with what? With fetal distress. Yes, fetal distress. We have acceleration of that deceleration of the fetal heartbeat and acceleration, both it is distress. And what is our management if we have fetus head in the pelvic cavity? Guys, we have now 9 minutes, and at the finishing of these 9 minutes, we begin again without break, in order to finish earlier. Understand, guys? Yes.
Yes.
I look for you. We need to. I need to find the inflammatory diseases, and KROK test devoted to inflammation. We'll speak about the inflammation the next hour. 28 years old Paturian complains about. We solve this test. Forceps operation, but it's not right. I don't like this. Applying of obstetric forceps, maybe, yes. Other methods is not useful here. Again, I don't stop. Cesarean fetus head in the cavity, embryotomy. We never perform embryotomy. It is destructive operation. That's why we never usually do not perform embryotomy if the fetus alive. We have a live fetus. Conservative labor management, we can wait only for severe aggravation of the condition of the patient. Stimulation of labor can cause further development of the fetal distress. The next, immediately after delivery, a woman had hemorrhage. Blood loss exceeded postpartum hemorrhage rate and was progressing. There were no symptoms of placenta detachment. What tactic should be chosen? No, woman has hemorrhage, blood loss exceeded, yes, and progress. That's why, of course, what we need to do, manual removal of the placenta. Uterus tamponade with placenta, it is impossible. The bleeding continues. Instrumental revision, it's very difficult to do. If we have the placenta, all tissues of the placenta, to remove with curate, it's impossible because uterus large. Yes, removal of after birth by Crede method, when we press above the abdomen wall the uterus and try to push placenta artificially from the cavity of the uterus. Now, according to new protocols, with this method forbids because very often it can cause the development of embolia. Then intravenous injection of methyl and gamethrine with glucose, usually it is cannot give us anything if the placenta stay in the uterus. Number 10. 30 years old Gravida consulted a gynecologist about bright red blood discharges from the vagina in the 32 week of gestation. She was hospitalized with suspicion of placenta presentation. Under what condition it is rational to conduct the internal examination for the diagnosis specification? Of course, if it is placenta previa, you see here, when you see placenta presentation, yes, it is investigation in the operative room, because even if we touch to this placenta, can appear profuse bleeding. That's why doctor need to be ready for operation in any minute. That's why investigation in the operating room. Usually this test repeated on KROK every year. Number 11. Secundipara has regular birth activity, second labor, it means. 3 years ago, she had cesarean section for the reason of acute intrauterine hypoxia. During paradynia, you know, guys, what does it mean, paradynia, guys?
The labor pains.
Huh?
The pain during labor. Yes.
Yes, paradynia, it is pain, and which woman feel? And usually it is contractions of the uterus. She complains of extended pain. It is contractions of the uterus. Sometimes some authors name this paradynia. She complains of extended pain in the area of post-surgical scar. Objectively, fetal pulse rhythmic 140 per minute. Vaginal examination shows that cervical dilation is 5 centimeters. Fetal bladder is intact. Guys, somebody, and it is reasonable question. Fetal bladder, it is amniotic sac. Amniotic sac, it is, they mean amniotic sac is intact. What does it mean intact? There is no outflow of amniotic fluid. What is management of choice? What is tactic of choice? Of course, what we have here, if the woman during contractions of the uterus paradynia has extended pain in the area,
cesarean section.
but what we have, how we can set the diagnosis? Eutemi. Yes, you are quite right. It is the risk of the uterine rupture. You know from the history that she has cesarean section. Yes, she has a scar, and during contractions of the uterus, we have very extended, strong pain in the area of post-surgical scar. Of course, it is the risk of the rupture of the uterus. That's why what we choose. Caesarean, yes, because fetus head above the pelvic cavity, yes. Obstetric forceps at all impossible if we have risk of the rupture. Wait, we can wait for the rupture only, yes, and vaginal delivery also can lead to the rupture of the uterus. That's why, of course, we choose cesarean section. And usually I want to say, guys, if to our clinic came with a woman with the scar, we plan cesarean section. And especially if it is, if the woman has pain in the area of the post-surgical scar.
Teacher,
yeah, I hear.
one question. How many times is it okay to do C-section for a woman?
How many times in no it depends on the religion, I want to say. Yes, for example, if we speak about the Pakistan, they don't at all. In our country it is 3 times, not more, because if more, you need to imagine we make the scars in the low segment of the uterus. With every operation, the tissues of this low segment decrease this amount of the tissues, because scar, it is transformation of the muscles. Yes, every time we remove this old scar and new fresh suturing and make a fresh suturing. And that's why if it is more than 3 cesarean, uterus can rupture even during pregnancy, not only when begin labor activity, but during pregnancy. That's why we permit to perform cesarean not more than 3 times. We receive the agreement from the woman, and usually after third cesarean section, we suggested sterilization for the woman section of the fallopian tubes by Pomeroy usually. Very often women ask us to do this sterilization after second cesarean section, and we agree with this. But for example, in Pakistan, they don't sign any permissions for sterilization, and they have 4th and even 5th cesarean section. But it is very severe, first of all, for the health of the woman. Understand, my dears? Yes.
Okay. And what if the first one was cesarean section and the second one was natural? Is it
We have
okay?
these cases. It is possible sometimes if the woman agree, if we have good labor activity, good condition of that cervix, we investigated the post-operative scar. If condition is normal of post-operative scar with the help of ultrasound, and we palpate it through the fornix of the vagina. If there is no pain, and if the woman, but I want to say, my dears, that doctors afraid of the second cesarean, and that's why in most of cases they suggested this second cesarean, afraid of the labor by nature, excuse me, if it was first cesarean. But we have cases, but if there is no insufficiency of the scar, why not? We have good needles now, we have good stitches, that's why not? It's maybe possible if it was cesarean without inflammation after operation. It is possible, and we have these cases. Yes, with a successful labor after first cesarean section. It depends on the condition of the post-operative scar and usually of the history. If the woman have any complications,